Welcome again to the Roxborough House Roundtables. Today we'll be discussing the Brittany Maynard case and the ramifications of physician-assisted suicide. We'll be talking about medical issues, ethical issues, psychological issues, and of course societal issues concerning that very sensitive, very important topic. Today our hosts are...
I am Ryan Long. I'm Assistant Professor of Philosophy here at Philadelphia University.
And Amy Baker, Associate Director of the Physician Assistant Program.
Okay, well, let's begin.
Okay. Do you want to give an overview of the
Sure.
case?
So Brittany Maynard is a patient who has gone on record in her final days volunteering for and dedicating her efforts towards end-of-life issues. She is a patient who was diagnosed earlier this year with brain cancer, went through a surgical procedure, and had a prognosis that she would only have about 10 years to live at most. Unfortunately, a few months after that, she was told that she had undergone a significant conversion of her brain cancer and only had about 6 months left to live. She has now spent her final days hitting items on her bucket list as well as advocating for death with dignity. And she is planning to commit suicide with her family at her bedside shortly after her husband's birthday, which is actually on the 26th of October, which is Sunday. So we're here today to talk about those issues. With us today we have...
Dylan Gormley, second year LNS major.
Andrew Thomas, fourth year PA student.
Holly Buchanan, a first year PA student.
I'm Lauren Jabe, third year Women's Society student.
Catherine Rick Miller, pastor of the East Falls Presbyterian Church.
Christine Kennedy, assistant professor of counseling, trauma and counseling program.
So I think there are many thoughts that kind of come to mind as we are thinking about this, both as individuals and, in many cases, future healthcare providers, providers that may provide pastoral care or counseling services to these patients. So what are some of the thoughts that come to mind as you consider this woman and her, her desire to end her life?
I respect it. I think everyone should have the choice. When you say enough is enough, you should be able to tap out in a dignified way, a way that you feel is going to bring you peace in whatever life you believe will happen after this physical one. And I think we shouldn't be forced to suffer through the pain that she's currently suffering in.
So this is Ryan Long again. So she moved to a state where this would be legal for her to carry out her plan. So you think in every state this should be legal, or in Pennsylvania we should make it legal?
Yeah, I think that it should. I mean, I don't want to say it should be legal. I just don't think it should be illegal. I think that there's a difference in my mind of that. I don't think that anyone should ever question anyone's decision when it comes to their own life choices, whether it be continuing or ending it.
Do you think that only applies in a case like this, where there is a clear indication that she has a terminal illness, or do you feel like it has broader reach than just terminal illness?
I think it should have a broader reach. I think anyone in general, for whatever reason you should be able to end your suffering, whether it be physical, as it is with Miss Maynard, or someone who is clinically depressed and who cannot get out of it shouldn't have to suffer through that either.
Still normally. My only issue with that, though, is that there could be a treatment for it, and death isn't exactly the right answer for that. I don't think. I do believe that you have the right to decide, I've had enough, I want to tap out, I want my life to be over. But when there are viable options to cure whatever's wrong with you, I think that you have a responsibility to go down that path. And just ending it isn't, I don't think that's right. I think that's...
Well, I mean, who are we to say you have to do this because there's an option available? Like, I don't think that we should be able to force people to continue to live if that's not what they think is in their best interest. And I think the person knows better than society or even I don't want to say better than their doctor. Their doctor probably knows the medical obviously better than them, but no one knows you better than yourself. And if you honestly believe that you cannot continue in this life, I mean, I don't think that you should be able to walk in and, get like aspirin. I think you should definitely have to go through some counseling and make sure that, because this is a permanent decision, but I think that this should be available to people.
And you think that it should be physician, or do you think it's okay to be physician assisted, like whether it's a terminal illness or like a deep depression, or do you think that a person has a right without, or like would a physician be responsible for this?
To be honest, I'm not quite sure the legal ethics that go with that. I know there's like a big deal with the Hippocratic Oath that you'll do no harm. I do think that there should be someone who has some sort of higher degree than just the cashier at Stop and Shop. I definitely believe that, but who that person would be, I haven't quite reached that determination yet. At least for my opinion.
This is Ryan again. So just to follow up, you think as long as the person is competent and makes an informed decision, whatever grounds they have for concluding they want to end their life would be permissible, as long as they're competent.
Yeah.
It's an interesting perspective. I can only speak to what is already on the books. Oregon is the state where Brittany is currently residing, so that this would be legal for her. And I did some research to figure out from a physician perspective what is required, and some of the things that you pointed out are actually things that are written into the law. The person, one, has to be making an informed decision. They need to be aware of the prognosis, and that prognosis needs to be confirmed by another provider, not just a single provider, because for sure we make errors in healthcare all the time. We do our best, but I know I've misdiagnosed patients, and we've worked through that and eventually came to the correct decision. They need to be aware of the medication and the risks of the medication. They also need to be very well informed of the alternatives. Are there other treatment options that they may not have considered or been offered in other indications? I mentioned already they need to see another physician, so it can't just be a single provider that makes this decision with the patient. And they need to be referred to a counselor. They need to have some counseling services as well. They also highly encourage that the next of kin be notified, so that this isn't somebody doing this in isolation and not being involved with this potential support personnel around them. And then there's some other medical determinants. They do actually have to have a terminal illness and have a definitive diagnosis that isn't just other options like you mentioned. And then the pharmacist has some responsibilities as well. So it does seem like there was some very intentional consideration in the way that this law was written to make sure that the patient was aware and reaching out to other people as well.
I have a question for the physician's assistants on our panel. Right now, your job is to save lives. That's absolutely what you are charged to do. How would this affect you in its two ways? One, that you're involved in the death of the patient without trying everything possible. And secondly, would it affect, do you believe, the medical profession of itself, knowing that there is this alternative of just ending it? Would that stymie research or motivation to find cures in some way?
I think definitely both sides. I think it would spur a lot more research in a lot of the terminal illnesses that we haven't found cures for yet, so that people aren't falling down this the slippery slope of wanting an end to any illness that's now presented. A lot of people don't know that there's alternatives. But I also think on the other end that, a physician's, with the Hippocratic Oath, it does say, we will do no harm and we will work for the good of the patient. And everybody interprets it in different ways. And I think a lot of physicians, including myself, I think that protecting the patient's life is our top goal. And if that means that the patient has a terminal illness, there's no other alternative, and the patient's really suffering, I believe that it should be an option for them to end their life with dignity. And do no harm. A lot of times these patients are in vegetative states or, paralyzed. They have no quality of life in their minds, and it's just adding to their suffering that they have to, live at people's whims.
I understand that perfectly, but put it in your mind, okay? You're the physician, you're the researcher physician, whoever it may be, and you have a patient who's suffering. Wouldn't it stimulate you to find there's always an answer? There's many diseases we treat now that years ago there was no answer for at all. Even 10 years ago, there was no answer for it. So the stimulation, I have this patient, she's suffering, he's suffering. I have to find something. I have to get something. That motivation may lead to you to find a cure, right? But if you know that you say, oh, they're suffering terribly, it's awful, let's end it. Does that sort of affect your motivation to find a cure if you haven't eased the out? I hate to put it that way, but it is.
I don't think it would, as a physician, I don't think it would deter me from being as motivated to finding a way to, cure the patient, find, a way for their quality of life to increase. But at the end of the day, it's not about me, it's about my patient. And I think that's what it comes down to. As a Catholic, my goal is to save everyone, life is precious, and I see that as a Catholic, but at the end of the day, working as a physician, it's not about me.
I think one of the big things that we work towards is patient autonomy. Mm-hmm. You were alluding to this, but our responsibility is to inform our patients so that they can make the right decision for themselves. And, my personal beliefs shouldn't influence the way that I treat individual patients. They should really be for me, and protecting my patient's ability to make their own decisions is one of the major components of being a healthcare provider.
This is Christine Kennedy from the Community and Trauma Counseling Program. I would like to say a bit about the hospice mission, which is to provide comfort, care, and symptom management to the extent that it supports a peaceful, natural death. I also understand from the case that she has decided not to pursue hospice, and I noticed that she said she's afraid of being in pain and suffering. And I also recognize that is the main objective of hospice, is to provide symptom management to the extent that the patient is comfortable. In my own experience, it was the pain that was the issue. Once the pain is addressed, the thought of, I want this to be over, has gone off the table. Then the focus is on relationships, my connections. My other comment is that from what I've read, I've read a lot about the legal position, right to autonomy. Certainly we have the medical ethicists jumping in, but not to jump into Ryan's territory, but what I'm aware of is that we have a long history of a philosophical tradition of many writers who, over the centuries, have written about, or these, their writings basically talk about endeavoring us to stay, that it takes courage to stay alive. That and it could be that our present worldview is ill-equipped to handle the harsh realities of what it means to be human. So maybe there's a deeper issue in play, that it's not just legal and medical, but there's a need for us to have voices that come forward to say, it does take courage to stay. Everything happens here. Relationships, happiness, joy, sorrow. And if perchance that we certainly have a lot of voices saying we need to give people the right, suicide should be an option, physician assisted, but where are the voices that are calling us to stay?
Does that kind of reasoning, do you think, so that would apply in one way to this case, which is to say she should not intentionally end her own life, because it could be a show.
Well, I guess the question is, what does she have to live for?
What does she have to live for? Is there anything objectively valuable?
Well, I haven't had the conversation. Well, I think that there's value, but again, I'm not Brittany.
Yeah.
I'm not part of her thought process. But I'm saying that we have a huge a vast amount of collective human wisdom over the centuries that has said, in the midst of these circumstances, in the midst of this pain and suffering, I endeavor you to stay. And, in her case, I don't know what that means.
I had a quick follow-up to what
Yeah,
you
sure.
said. This is Ryan again. Maybe people know my voice now. You said it's usually when patients are deliberating about this issue, it's usually a question of pain, and then if the pain is managed, the impulse to make the decision to end the life is usually no longer attractive. Are there any cases you've been exposed to where there were other concerns, such as not wanting to be a burden on people?
Oh, absolutely. Well, I was using pain in a broad sense.
Yeah.
So it's not just physical pain,
that. Okay.
psychological pain, spiritual distress.
Because
Absolutely.
and how do you? So I was thinking of treating pain with drugs, which could perhaps help the physical pain. How do you help patients who feel that they are a burden to their families and that there's no hope? Can that be alleviated somehow? How do you alleviate
Well, I would
that?
say absolutely. I mean, that's the goal of hospice, is to provide the support in all areas where pain may be an issue.
It's interesting that you actually bring that up, because I did some research in anticipation of this, and I looked at the numbers of patients who had received prescriptions and the comparison to how many have actually used their prescriptions. And it seems like in any given year there's a difference between about 30 to 50 patients that receive the prescription and have it there in their medicine cabinet and then don't use it for whatever reason. Maybe they don't have the opportunity, maybe they've changed their mind, maybe they have other resources like hospice that they decide is a viable alternative to them. But that certainly does seem to be weighing into even individuals' decisions. If there is another route to alleviate pain or the concerns about staying alive longer, then I think that must play in somehow to at least a percentage of the people's decision making.
If I could just pop in, because I've had, it's anecdotal, but it's 2 years ago, I lost my mother and I lost my father-in-law, very close, 2 months, and they both went through the hospice experience. So I think I'm fairly at least familiar with it. You were talking about pain of family. The whole family were there at the bedside of my mother and my father-in-law for 3 days. And my father-in-law and my mother, were basically out of it, on the morphine that they were given, so they were there, basically not there. And I do believe that the family would have been spared a considerable amount of pain if physicians were allowed to decide, okay, there's no hope here. This is obviously they both had terrible conditions. There's no coming back from this, and would have been able to, with those drugs, give a little more and put my father-in-law and my mother to sleep. And instead, we had to sit there and do a death vigil for 3 days. And that was extremely painful. I can tell you that my sister still hasn't recovered from that. And why was that necessary, to put the family through that? So that's how, I think that's what you were going for on that. Because it's just not the pain of the person. Because in hospice, you do excellent job. They were not in pain. Absolutely not. They weren't even there. I mean, they were there, but they were out. So I put that out there, and I'm just interested in people's take on that.
Well, my one comment from experience is that, I can't respond specifically to your situation. I do understand you saying how painful that is to provide a vigil. And on the other side of that, I've had experiences where families, after the vigil and after some time to reflect, actually expressed a very different perspective because they had a chance to reflect on the experience and say that despite our pain and what we evidenced, we felt that that there was a learning or there was something that arose that was of value. I'm not denying that that's a very painful situation, but again, there are some traditions that believe that that moment when there's intense suffering, there's also potential for the mystery to unfold and something comes forward. You might want to comment on that.
Catherine Rick Miller, pastor of East Falls Presbyterian Church. And a couple of things strike me. One is that death is holy ground, and that we all have really powerful memories. Some of them are incredibly hopeful. Some of them are even full of joy. Others bear the mark of pain on us that cannot be removed. And I have often heard it said, and this echoes a little bit of what Christine said, that I'm not afraid of death, I'm afraid of dying. And even of being with someone who is in that process of dying. One of the issues that it makes me think of, too, is control. Most of us really want to be in control, to know that we're in control, and to plan out with control things that sometimes are in our control and sometimes are not. And there is a long history in the Judeo-Christian tradition, and in other traditions as well, of a journey, and of life being a journey. And a mother has to labor for a child to come into the world, and death is often a labor. And it is, on the one hand, healthcare has let us prolong death in some cases, which I think speaker alluded to earlier. And there are times where we're just prolonging death. This moves further in that step of bringing death forward. And it gives us a level of control that sometimes we want. Maybe we should have, maybe we shouldn't. And I think, but that sense of journey into the fullness of life and into the death, and something we do together. And sometimes maybe our job is to be present with each other in that journey, and to really be honest about those issues of isolation, of pain, and on all kinds of different levels of control that we're all going to struggle with all the way through life, but that really get identified strongly emotionally at the end of life.
I know one of the things that I've actually seen with our students who come back from rotations in their second year of the professional phase of the PA program, for many of them it's the first time they've seen somebody die or been with somebody as they have died, and it's a great source of anxiety for students and for healthcare providers as well. So I can relate to your desire to control it. We see it in labor and delivery, inductions, cesarean sections. We're now maybe seeing the flip side of that in physician assisted suicide, and I think it's important to at least acknowledge that. What you do with it once you realize that some of it is our desire as humans to be in control of things that maybe aren't in our control, then might allow us to process some of the way that we feel about these things in a different way.
The transition from when you went from just books and studying about everything to when you actually got out there and saw people die, what was that like? I mean, that must have been a complete shock to the system. I mean, I'm sure you've gone through it. It just, having seen it firsthand, you must feel at least a little bit that this whole situation might be, I don't know, just wrong.
So I come from a different perspective in that my first experiences with death actually weren't as a clinician. They were as a family member. As I was younger, I had an aunt who died of lung cancer at 36. A few months after that, my grandfather died of congestive heart failure. I had two grandmothers who died of breast cancer within a short period of time. And I think the first time that I saw somebody die, I was 14. And then I worked in a nursing home. And in a nursing home, when you're 18, 19, 20, death is all around you. You learn to appreciate the life that somebody has lived and sort of separate that in some regard from the death that they have to die. You focus more on the life that they they got to live. So by the time I became a clinician, I saw it in a different light. I saw it as, as an observer in somebody's life and being part of that journey that Catherine alluded to. It is very different being a clinician, and I am not sure. I know how I feel about it if I were in that situation. I'm very much a control freak. I like to be in control.
Yeah.
And so if I put myself in her shoes, I think I might make the same decision that she made. I can totally relate with her opinions. However, my my faith makes me think that maybe that's not my job to be in control of this. For family members, I wish that had been an option for some of my family members. It wasn't, but I wish in some regard it would have been, because there was terrible suffering on the part particularly of my grandmother. And then to be on the side of a clinician, it's hard because I imagine some of my patients coming into me and saying, "Hey, Amy, can you help me? I don't want to do this. I can't imagine doing this." And the statistics say that, you guys in the room who are physician assistants, some of you will be approached by this. Somewhere between 1 in 10 and 1 in 5 of you will have a patient ask you, can you help me, leave this life?
So then the issue kind of becomes,
so I'm not sure how I
you've been
feel
so
about
numb
that.
to it for, if you're around it that much and you get into a situation where a patient comes to you and says, "End my life," and you've been numb to death, I mean, you're probably going to say yes.
I don't know that I would, though. When I think about it, I don't know that I would, because I feel like that is a situation where maybe that's not my job, maybe that's not my role, and maybe it is. I have not been approached about it ever. I certainly have one patient who I think might have asked me, but he didn't. And I wouldn't say that I'm numb to death, just to clarify. I think I just am exposed to death, and I think I
Do you
appreciate
think
the
that's a
intricacy.
possibility that after working with?
Oh, for sure. I think particularly in the emergency room where you see death all the time, you see patients come in and they're described as the patient who was dead on arrival, as opposed to Mr. Jones who had a car accident. I think that's definitely possible as a healthcare provider. I don't think I'm there, thankfully, but it seems like I have the desire to help, but I'm not sure that I have that sense of responsibility. Maybe it's not for me to decide, though I don't know. I really don't know.
It's Catherine again. I had this conversation with my dad who, started practicing. He's an internist. Has been practicing, went straight through medical school, residency, and he's now retiring, in the process of retiring at about 67. He still remembers the first deaths and is definitely not numb to it. And maybe there's a difference between becoming numb to it and being able to reduce our anxiety as pastors and healthcare providers and counselors, so that we can be present, so that someone else's anxiety doesn't kick up our anxiety, but that we can meet someone exactly where they are without being numb, but without being anxious, and be present and hear the story behind the story, the music behind the music. I just heard of a class for physicians on observation, and really observe what's going on in the patient and in the community of the patient, the family, the friends, the faith, whatever all those factors are, and then be really present without our own anxiety creeping into what we want for the patient.
I have a control came up a few times in the last few questions or comments. Sorry, this is Ryan again. And I had a question what people thought about control. So this case is, legally and socially interesting, probably because there's this shared moral intuition that there's a high level of control going on in this case. Right? This is a very carefully planned case of killing, not just letting someone die, but a killing, and that there's a shared intuition that that's something morally weighty, right? And it's legal in Oregon, and it's not currently legal here. But why do we have this shared assumption that this case is worth convening a roundtable about and worth deliberating about? Maybe it's not that special. There are other kinds of cases that happen in Pennsylvania and everywhere else where a patient could take steps for medical intervention that maybe they don't have a great long-term prognosis, but it's not hopeless, and they make a decision not to do it, okay? And then it happens that they die. They're not killed, but they die. Or there's a medical intervention happening, and then you withdraw the intervention, and then the patient passes away. They aren't killed, but human agency is involved somehow. Somebody could just say, this case is no different from those cases, and we're kind of sharing an illusion that there's something special here, when there's really no difference between reaching a decision that will withdraw treatment versus prescribing these pills. I'm not saying that's my opinion, but is that plausible? Like, are we mistaken in thinking this case is special? Or is there a reason to think there's nothing special about it? We already do these other cases. We should obviously do this case.
So I think there's a bunch of different sort of ways that you can classify death as occurring in perhaps an unnatural way. There's euthanasia, which I think more people are against, where you have somebody who is at that point oftentimes in a vegetative state, but not always, where the physician actually administers the medication. And I think that's illegal everywhere from what I understand. Then there's what you pointed out, where care is withdrawn, where there's some sort of intervention that is life-sustaining, and that care is withdrawn. And that's done all the time, every day in Philadelphia, without much question. Maybe it isn't really all that different, versus a case like this where the medication is prescribed, but the patient administers it on their own. And then there are situations that you have in hospice, for example, where some of the medication that we use to control pain might actually hasten the death unintentionally, but many of the pain medications are respiratory depressive and slow down somebody's breathing, and they just can't tolerate it. So, I think what makes this situation different is that it's sort of in the same category as euthanasia. It's not prolonging somebody's. It's not prolonging. That's double negative. That doesn't even make sense. It's not choosing not to prolong. That's still not working.
I think, Amy, the affirmative act is involved.
Yeah, there's an intention.
There's an intention where if you don't treat, it becomes natural.
Right.
When you give the extra dose of morphine, what it may be, that is an intentional act to end a life. So I think that commission instead of an omission makes all the difference in the world for some people. And I'm not sure it should. And that's something. But I wanted to bring up. Did you have a response?
Well, yeah.
Go ahead.
Well, when you were talking about euthanasia, it kind of reminded me of the Dr. Kevorkian jury selection. The lawyer made this great point where he asked the jury, how many of you have ever had a pet? And how many of you have ever had to put that pet down? And it makes you think, like, I didn't do that. Like, I did it out of love. The same reason why people would maybe want to do that commission action. Just because, you're doing it out of love. You're doing it because you don't want to see the person suffer. You don't want to see yourself suffer. You don't want to see the people around you suffer. Just want to say that.
It's one of the major arguments is that this is an act of compassion. Mm-hmm. And if you would do it for your cat or your dog, why wouldn't you do it for grandma? But I think that argument only gets most people so far.
Well, talking about it being an act of compassion, like our mandate is like do no harm, and thinking about keeping them alive against their will, perhaps that is creating more harm than actually being able to help the individual. And I do think that ultimately, I hope that it's the physician or healthcare provider's responsibility in the end. I know that we tend to relate to this as individuals, but I do actually think that it is the responsibility of the healthcare professional, because I don't know who else would be there and have the ability to provide them with this service.
And I think going off of what Holly just said, there was, I think a lot of people know about the case back in Spain, I believe, Ramon San Pedro. He fell when he was diving, and he became completely paralyzed, and he led a 28-year campaign for euthanasia. And we say we don't want to do any harm, and at the end of the day, he actually systematically had friends and loved ones help administer a lethal dose of potassium cyanide, and he drank it, and he committed suicide that way. But the sad thing is that what he's going to remember at his last moments is that he spent 28 years trying to get euthanasia, trying to have that become legal, rather than, when he decided 28 years ago that this is it for him, he didn't have that option, and so he spent 28 years, and those are going to be his last memories.
You bring up a really good point, okay? Because we've been talking about people who are about to die, who are dying. But you bring up something completely different, a quality of life situation. Someone, for example, has ALS. They don't die for a long time, but their lifestyle is, some of them may believe, just intolerable. But they're healthy otherwise. Or someone with advanced Parkinson's disease, or MS, or any of these diseases that the person is alive and will live for a decade maybe, or two, but will live in their minds miserably. Do we extend physician-assisted suicide to people who are living and healthy otherwise, but their quality of life is intolerable, like the gentleman you brought up?
I think it really, it sounds like an out, but I guess it really is case by case. And I think it should require a lot of counseling for the physician and the patient. It could be equally as traumatizing for the patient as well as the physician. But a lot of people, when they decide they want to commit suicide, you'll actually hear stories where right before they're about to commit suicide, attempt suicide, everything becomes clearer, and now they decide they want to live, and they end up living a great life, whether it's medical or depression. So I think it should definitely require a lot of counseling to make sure patients know that this is exactly what they want, rather than they take whatever the prescription is and then realize I could have lived for a little bit longer. A lot of times, right in that last couple moments of life, you hear stories that that people end up living and everything became clearer.
I have a follow-up on this one. I'm sorry, I don't remember your name.
Lauren.
So you definitely think the answer to Evan's question is it should be permissible, right? Because you said if the patient makes a free choice, it should be respected. So, so here's one way we could maybe form an argument against permitting this. So your position sounds like it's based on respect for patient autonomy. We shouldn't impose our view of what's good and desirable on a patient who's competent. And that does seem to show respect for the patient. So here's one thing we could worry about. I'd be curious if you or anybody else cares about it. Sometimes the patient could just be objectively wrong about what's in their future best interest. So this was the case where you said, well, they have a condition that's in fact treatable, even though they've decided they don't want to treat it. Should our concern for the patient autonomy trump this worry, or should sometimes we think, well, if what justifies assisted suicide is that it's not doing harm, it's in the person's interest, but if the person could be wrong about what's objectively in their interest, maybe we should have stricter laws or not allow it. Or that would be the worst case scenario, right? They make a mistake and assisted suicide happens and it wasn't in their interest.
Well, I think it's important in that case to have it be like a team of individuals. So it's not like physician first, a patient. It's like, a counselor, the loved ones of the patient, and another physician or healthcare provider. So it's not just like the opinion of one person, but like a group of.
And I think that's how the Oregon law is structured. is so that it's not one patient, one provider. It's really made much more as a team decision. Kind of going back, I guess backtracking a little bit to what you said, about the clarity of maybe I really do want to live. I think that's to bring it back around to this particular case. She says, look, I don't want to die. I am not suicidal. I want to live. I truly want to live. When she found out that she was had brain cancer, they were trying to have a child. And so I think there is that differentiation between I want to die versus I am dying. I really want to live, and it's not in my cards. It's not going to happen for me. So I think that differentiation in my mind is important. I'm not suicidal. I want to live, but I'm not going to. And how do I regain some control if that's important to that particular person?
Her comments that were so interesting, because when I raised the possibility that there's actually no difference between this case and merely withdrawing treatment, and then Evan or somebody else said, what's happening here? Is there a human intervention that causes the death, that's a killing, or is it quote unquote natural causes? And some people think that difference really matters. And her comments there were attacking that whole view. She was saying, I think I read a quote where she said, the pills aren't going to kill me, right? The cancer is killing me. She's saying the fundamental cause is already determined. And so this thinking about, is it human intervention or not, she denied that in a very interesting way. That's just a comment.
Kind of like she's trumping the cancer with pills.
Yeah. Or it's like causal overdetermination or something. Like it's already happening immediately. And this is not
But it goes back to what you said about control. It gives her agency. At least her death is her decision and not the cancer's.
Yeah.
Kind of going back, this is suicide, right? And kind of going to what June said, we want to give them a nice final day, nice, you want that person's final moments to be peaceful. Some of these people who take these pills probably, I don't know if there's a study that says how many would have killed themselves in the conventional suicide methods, but I think it'd be a better way to end your life knowing that you're going to do it anyway, but you'd rather be surrounded, do it in a way that you can be surrounded by your loved ones, and I don't really say this lightly, but not make a mess. You don't have people that are going to be traumatized as significantly by this.
This is Christine. I keep thinking that there's a deeper another conversation that we need to have, and that is that we seem to be living in a society where we're very death phobic. That we continue to promote that if this human experience happens and it ends, it should end when we're at the top of our health and our cognitive ability to make that decision. And so, because ultimately, the human experience does involve pain and suffering, oftentimes, but it's also, the flip side is also possible. Joy, happiness. So I think we need to be thinking about how is it that our society or our collective thought system is giving rise to or even supporting these opinions about that we should have the option of or that we can somehow relieve ourselves of experiences that are part of the human condition.
And I think messy is part of the human condition. It is messy, and we want to sanitize that, and we want to keep it at bay. But I can also say, from 12 or so years of being with people in the messiest of times, those are also incredible times of growth and of change. And so sanitizing ourselves from them is also sometimes keeping ourselves from something that's also can be beautiful and growth-oriented.
I would like to respond to your question. I spent 15 years in hospice, and many of the years were spent holding 20-year-old men, 18-year-old men who had contracted AIDS and who had no one to care for them. And I have to say that in terms of suffering or the symptoms that they presented, they were devastating on a variety of levels. But I think what I learned in that process is that being present to, as much as I could, being present to that suffering and providing that support, there were some amazing transformations that occurred. And certainly, so that's why I'm at a tug. I certainly would never want anyone to be in intractable pain unnecessarily. And yet at the same time, I also don't want anyone to miss how wonderful it is to be part of this collective human family where often that web is invisible. You know, when I think of my depressed patients, the thing that they don't recognize, amongst other things, is that they're part of a wonderful collective where they matter to someone. They may not be able to see that. Does that mean that because they can't see it, that they should have an option that, you know, being out of pain is better? I don't know. I think we need to do a better job of having these kinds of conversations where we're all engaged. It's not an easy decision, but I think that we need to be, you know, to be talking about them, or talking about this beyond today. So.
I'm curious, this can go to the peanut gallery too if they want to talk. If anybody who works in the medical field or will be, does anyone support this as a policy matter and think it should be permissible, but you don't want to be the person who prescribes the pills? Or everybody has that view?
I think that's one of the reasons that I feel so conflicted. You know, what you're talking about is, you know, you mentioned becoming numb. I watched my grandmother struggle for days. You know, she would take what we thought was her last breath, and then it wasn't, and she'd keep breathing. And, you know, we would pray, you know, please let it end. But I also feel like that was a very therapeutic time of my life as well. And so, you know, having been there in her final moments and seeing that made me realize that maybe death isn't as scary as I would have thought. And that's why I think I feel so conflicted, as I don't know that it's my job as a physician assistant or a physician or anyone to say, you know, your time is over. So I think that's very much at the core of how I feel. And I, you know, as I looked around the room, I saw many of my students sort of shaking their heads as well.
But I don't think that we're like making the decision that it's time for their life to end. We're just supporting them, you know, in the ways that we can, which happens to be assisting them in shortening their lives.
Yeah.
And also, like, going back to like the messiness of death, I think that by ending life early, it doesn't necessarily, it's not clean, it's just a different type of mess. You know, you're still going to have to like go through some emotional growth and relationship issues, and you just get the opportunity to like have a little bit more control over it and kind of guide it, but it's still going to be a growth.
Right, yeah, choosing to die is, I'm sure, not an easy decision either. You know, choosing to live has to be extremely difficult for this woman. I, you know, put myself in her shoes, and I can't imagine having all of that in front of me, having just gotten married and be looking forward to having a child, and have that right there, and, you know, your dreams at your fingertips, and then having them taken away. So choosing to live seems really difficult. What she's facing is really hard. But choosing to die is taking a leap into the unknown. And, you know, I like to think that there's something beyond this life. I've seen the analogy that, you know, when babies are in the womb, they think that that's all life is, and then they're born, and then look what's so amazing afterwards. And maybe death is the same way, and we just don't realize it, but it's unknown. We have no idea. So I'm sure in her situation, choosing to die is equally scary, is equally hard.
I just raised one issue, and I think everyone has really covered amazingly here all the elements of it. One thing that is missing that we haven't discussed is the law the way it is in most states does not give you that ability to make the choice. And we can see many people here would have different choices based upon a myriad of different very interesting ideas. But the law in Pennsylvania and New Jersey doesn't give you that choice. And I'm just interested, before we wrap up, even if you think this is something, is a growth thing, a journey thing, as you put it, part of the human experience, there are people who wouldn't agree with you, or perhaps don't want to go down that path. Shouldn't they have the ability to do what they want to do? After being counseled by people like yourselves who say, hey, these are things you should be aware of. And at the end, if they make the choice, shouldn't they have the legal right to proceed the way they want to? So I'm just interested in what your, just go down the panel a bit.
Evan, I don't know if you're aware, there's actually a proposal that's in the judicial board, I believe right now, for consideration through the end of this year in the state of Pennsylvania that has laws that would mirror what is in place in Oregon. It's something that I came across. Now, who knows where it will go from there, but it is something at least that Pennsylvania is thinking about.
So that is a real live issue right now.
Yeah.
With this panel, just going through support that bill, doesn't mean you support that choice. You would probably never ever want that choice, but would you support it as a choice? I just thought our counselor over here.
Christine, I have to think about that because, again, I'm like Amy. I'm very conflicted myself, and I think when you asked me if after counseling someone, well, that at the moment it remains anecdotal. When it's an experience, I'll get back to you. I mean, because from my perspective, I really do want to support the client's integrity. At the same time, I know that we're part of a wonderful collection of human wisdom that suggests that, we need to think about not only, we need to think about our position in the universe and our place in the world as being a part of a larger community, and that my exiting from that community impacts the community in some way. But I haven't worked out all these issues. All I can say is, I certainly would consider it. I guess I have a lot of thinking and talking to do, which I suppose we all do.
Yeah, I would echo that. I do appreciate the very narrow scope of the Oregon law. How many people, Amy? It's
in this past year, 121, I think. People got prescriptions as of January, end of January. 71 had committed suicide through these means. And that's the most it's been in any given year. Sorry, 122 and 71. Each year, since it's been introduced, somewhere between 16 and at most 85 have used this route.
So the way that Oregon law is written, it's very narrow. We've kind of broadened it a lot in our discussion, but it's incredibly narrow. And I'm a huge proponent of this public conversation. Christine hedged, I would say that if you held me down right now, I would want to say no, I'm not going to be in favor of it, but I do appreciate the really narrow scope. And I really appreciate the conversation. And I hope we can have more of these conversations. And I could change my mind because I also can't imagine being in that situation or sitting with someone in that situation. And it is something that I have wished and wanted and prayed for people for whom I know death has lost its sting. And there are things that are worse than death. And I'm very comfortable with that. We've never, as a country, maybe just as humanity in general, been good at legislating these kinds of issues. And that, it's not. So it does take on a different tone when you talk about legislating it.
I think it's pretty clear that I'm very much for it. I think with proper guidance from a whole bunch of different areas of life, both the medical, the physiological, all that. I think we haven't any manner of coming to this kind of decision. So I think this is that is a bill I would definitely support.
I am also a proponent of such policy. I came here today mainly because I thought about myself if I were in this situation, or my loved ones, and I would hope that they had this option. And as a healthcare provider, I would like to be able to give my patients this option, or I would like it to be legal in Pennsylvania. I would like to be able to assist loved ones, patients, in leaving with dignity and integrity.
I would also say that I'm a proponent. Again, I really do like the narrow scope of the Oregon law, and I think while working in hospitals in the past, I've seen death throughout the ages, and I don't think that it makes us numb. I think it never gets easier to deal with, to see death, but you do learn how to cope throughout the years. And would I ever be the physician filling the prescription or writing the prescription? Time will tell, but I think in the meantime, I would say I am a proponent.
I'm for it. I think that everyone has a right to decide what they want to do with their life, and if they want to end it, that is their right, and the government should back our rights, period. It's our decision, and we should be supported by the government.
So I think this already happens, and I think when it happens in secret. And so I think that making it legal in a very narrow, appropriate window in patients who have no other alternatives seems reasonable in my mind. I almost hesitate to even say that. I don't know that I could write the prescription, but maybe I could. Maybe I would find the patient that I thought this really was the only compassionate thing to do for that particular patient. But I think without these kinds of conversations, then it will be done. It will be done no matter what we decide as a country. And if it's not illegal, then we don't penalize people for making decisions that we might not make for ourselves. And I think that's why I would probably support something like this.
I haven't read the Pennsylvania bill, so I won't say I support it. But from what I know about the Oregon law, I would definitely support a law like that. And I just wanted to throw one other wrinkle out. So I heard once or twice, well, when Evan raised this question, he expressed it in terms of rights. Should a person have the right to do this? And I think I heard a couple people repeat that term. And some people think the Oregon law is too narrow. But one puzzle to think about is if you're not just saying it's permissible, but that the person has a right to do it, that right is empty unless they can make it effective, right? And that means if they're incapable of ending their own life, it's obligatory on someone or the collective or all the people in the state to help them make that right effective. So if you're doing it in rights-based language and you think it should be not as narrow as in the Oregon case, that has strong implications. That means it would be morally wrong not to assist somebody who reaches the conclusion that they want to end their life. And so if you combine that with this view that it should be of wide scope, that has pretty huge implications. And that I'm undecided about. But something like the Oregon view sounds good to me.
I think that's an excellent time to wrap this up. I really want to thank all of you. This is an extremely sensitive topic. I agree with what everyone said on this panel, that this type of discussion is extremely important. And as opposed to the discussions you see on television where people screaming and yelling and you learn nothing. Actually, we all listen to each other today, and I think this is a perfect example of how discussions should be, because I think it's the only way we can learn from each other, especially on topics this sensitive and this important. I want to thank everyone for coming, and please feel free to be part of any other panel in the future. You folks were really informative. Thank you very much.
Thank you.
Thank you.